I was raised on a dairy and beef farm in central Alberta. On the farm, it was never his or hers or their work. It was just work that needed to be done. We would adjust the priorities within the boundaries of what was non-negotiable while being flexible to what was out of our control. It felt good to be a part of something bigger, especially during the excitement of harvest as neighbors and family pulled people and equipment together to tackle the work and move to the next farm to do it all over again. Those relationships with family and neighbors were cherished. We knew that we needed each other. As a frontline nurse, those lessons of teamwork that I gained from my previous work life were invaluable to my practice. Soon, I was participating in quality improvement committees, and my acute care unit was selected to be an innovation unit. We began piloting rapid rounds. We had a social worker, an occupational therapist, a transition coordinator, a physiotherapist, and the nursing and administrative staff all working on the same unit. As the orders came from the physicians, the rest of the team worked separately to carry them out. It was perceived as one big team. We assumed that everything was working well. As the rapid rounds began to unfold, we realized quickly that we collaborated with a chart, but not one another. We assumed that the doctor would review the documentation, that reports were filed appropriately, and that everyone understood the jargon used. Relationships that allowed team members to be comfortable enough to ask questions had not been established because we hadn't worked in an integrated fashion. It was clear we needed to engage with each other differently, so we got to know each other's names, who had kids, who had a dog, who loved to bake. And as rapid rounds evolved, we learned together how the overlap in our scopes could result in a stronger network of support for patients and their families and for us as professionals. Our collective wisdom caught errors, filled in important details, and even helped us provide extra help for the marginalized populations we interacted with. Eventually, it felt like those harvest days on the farm, and our motto became, what do we need to do? Who's in? Who are we missing? Let's get to it. Within a year, our average number of admissions went from 50 per month to more than 100 as we were more efficient in our care planning. 4 years later, I joined the North Zone primary care team. I was excited about the primary care networks, the patient medical home model, and the interprofessional approach to health promotion and disease prevention. I soon found out there were many of the same barriers and challenges like we had in rapid rounds, just on a larger scale. People were speaking different languages, had different mandates or priorities that didn't always align, and even some past mistakes had created barriers to relationship building. Eventually, a new mandate by Alberta Health to work as an integrated team to plan services within our zone led to the development of local health neighborhood coalitions, with local partners from PCNs, patients, Alberta Health Services, and community agencies all working to build relationships, understand each other's perspectives, and achieve the collective wisdom that is necessary to support and improve the health of our communities.